Assalamu alaikum, good morning everyone. Those are listening in the morning, good morning. Those are listening in the evening, good evening. And I am presenting a topic which name is Ankylosing spondylitis, and I will try to explain in front of you people as much as in detail what I know. So definitely I will try to present few pictures from the internet and from the book, but I will present one case for the analogy to understand this disease with full confidence and with full knowledge. So first of all, ankylosing spondylitis is a chronic inflammatory disease of the axial spine, and the chronic back pain and the progressive spinal stiffness are the most common feature of this disease. Involvement of the spine and the sacroiliac joint and the peripheral joint and digits and the anthesis are characteristic. Impaired spinal mobility, postural abnormalities, buttock pain, hip pain, peripheral arthritis, anthesis, and the dactylist are all commonly associated with the ankylosing spondylitis. Actually, I want to present here especially the differentiation between the ankylosing spondylitis from other condition with similar presentation, and I want to present here that an appropriate diagnosis, imaging modalities for evaluation of the ankylosing spondylosis related changes, and I want to present like that we can apply the knowledge of available pharmacological and non-pharmacological intervention for the ankylosing spondylitis, and definitely and we can how we can care this kind of problem. Ankylosing spondylitis is a chronic inflammatory disease primarily affecting the axial spine that can manifest with the range of clinical signs and symptoms. The hallmark feature of the condition include chronic back pain and progressive spinal stiffness. Ankylosing spondylitis is characterized by the involvement of the spine and sacroiliac joint and peripheral joints, digits, and anthesis. Ankylosing spondylosis often lead to impaired spinal mobility and can result in postural abnormality. And patient can also experience buttock pain and hip pain, peripheral arthritis, enthesitis, and dactylitis means sausage kind of digits, and I want to show you here how the sausage kind of digits. Actually, I took this picture from the internet to show you how this is. We can see the sausage kind of digit, so you can understand the digits are sausage kind in the ankylosing. This and a sausage kind of disease, the digits, not only in the ankylosing spondylitis but also in the psoriatic disease. So it can be combined with the psoriasis or psoriatic disease. So in addition to the skeletal involvement, ankylosing spondylosis can affect various organs outside the joint. These intra-articular manifestations of the ankylosing spondylitis include inflammatory bowel disease affecting up to 50% of the individual and acute anterior uveitis seen in 25% to 35% of the cases. You know that there is this extra-articular manifestation of the ankylosing spondylitis include inflammatory bowel disease and affecting up to the 50% of the individual and acute anterior uveitis seen in 25 to 35% of the cases and psoriasis approximately in 10%. So, ankylosing spondylitis is additionally linked to an increased risk of cardiovascular disease, which is believed to stem from the systemic inflammation present in individuals with ankylosing spondylosis. Pulmonary complications are also associated with the ankylosing spondylitis, as diminished chest wall expansion and limited spinal mobility can predispose individual to a restrictive pulmonary pattern. And finally, individuals with the ankylosing spondylosis are at least twice as likely to experience vertebral fragility, fracture, and additionally, they face an increased risk of atlantoaxial subluxation and spinal cord injury, and rarely quadra equina syndrome. Regarding, if I say about the etiology or the cause of the ankylosing spondylitis, the cause of ankylosing spondylitis remain largely unknown. Means unknown, we don't know exact cause of the ankylosing spondylitis, but however there appear to be a correlation between the prevalence of the ankylosing spondylitis and the presence of human leukocyte antigen, we can say HLA B27, in a given population among individuals who are HLA B27 positive, and the prevalence of the ankylosing spondylitis is approximately 5% to 6% in the United States. The prevalence of HLA B27 varies among ethnic group, and in 2009 that was it was established that the HLA B27 prevalence as 7.5% among non-Hispanic whites and 4.6 among the Mexican Americans and 1.1% in Hispanic black. So these are the HLA B27 means presentation in different races or different sectarian group. Ankylosing spondylitis commonly present in individuals younger than 40, and with approximately 80% of the patient experience their first symptom before age 30, and less than 5% are diagnosed after the age of the 45. Ankylosing spondylitis is more prevalent in men than women, and however they are increased risk of developing ankylosing spondylitis in relative of the affected patient. So it is a genetic involvement also, but male predisposition is greater than the female. If I talk about the pathophysiology of this topic, so I must say, so ankylosing spondylitis, as I mentioned, this is a chronic inflammatory disease, and that typically present gradually and without obvious early symptoms, and the disease is characterized by progressive musculoskeletal and often extraskeletal sign and symptom, and the rate of disease progresses can vary among individuals. And the primary pathology of the spondyloarthropathies include the ankylosing spondylitis, include ankylosis, and this chronic inflammation involve infiltrating immune cells such as CD4 and CD8, T lymphocyte and macrophages. Cytokines, particularly tumor necrosis factor alpha and tumor necrosis factor or transforming growth factor beta, are also important in the inflammatory process. So these two cytokines and these two infiltrating immune cells such as the CD4 and the CD8 T cells and the macrophages are playing important role in this chronic inflammation of the spine, and associated these cytokines, particularly tumor necrotic factor alpha and transforming growth factor beta, are also important in the inflammation process, and they contribute to the inflammation, fibrosis, and the ossification of at site affected by the ankylosis. So Regarding, if we talk about the history and the physical, in suspect case of the ankylosing spondylitis, a comprehensive elevation of the entire body is recommended due to the systemic nature of the disease and its potential involvement in multiple organ systems, and the back pain is a common complaint among patients, and the characteristic type of the back pain in ankylosing spondylitis is inflammatory in nature. So, in suspected cases of the, we can say there is ankylosing spondylitis is a comprehensive evaluation of the entire body is recommended due to the systemic nature of the disease and its potential involvement in multiple organ systems, and the back pain is a common complaint among patients, and the characteristic type of the back pain is for example, we can say ankylosing spondylosis is inflammatory in nature, and the presence of the inflammatory back pain is characterized by least 4% of the following 5 features: an onset of symptom before the age of the 40, gradual and insidious onset, relief with the exercise, and the lack of improvement with rest, and nocturnal pain with improvement upon arising additional spinal stiffness, and the limited mobility and the postural changes, particularly hyperkyphosis, are frequently observed. So during the evaluation, the patient's history and physical examination should address all body systems, as ankylosing spondylosis can manifest with the axial and peripheral musculoskeletal symptoms and extra-articular feature. A detailed medical history should be obtained to identify or rule out associated conditions such as psoriasis, inflammatory bowel disease, and uveitis, among others, and that may be correlated with ankylosing spondylitis. As I mentioned here, that during evaluation, the patient history and the physical examination should address all body system, especially when we are trying to considering the ankylosing spondylitis, because it can manifest with the axial and the peripheral skeletal muscle symptoms and the extra-articular feature. A detailed medical history should be obtained to identify or rule out associated conditions such as psoriasis or inflammatory bowel disease and uveitis, among others, and that may be correlated with the ankylosing spondylitis. As you know, there is if we consider there is, for the evaluation point of view, the laboratory finding in ankylosing spondylitis are typically non-specific but may provide supportive evidence for the diagnosis. And the approximately 50% to 70% of the patient with the active ankylosing spondylitis show elevated level of acute phase and reactants such as erythrocyte sedimentation rate. It means you will find the elevated erythrocyte sedimentation rate and you will find the elevated C-reactive protein. However, a normal erythrocyte sedimentation rate and C-reactive protein should not be used to exclude the possibility of ankylosing spondylitis. Several imaging abnormalities, especially these affecting the spine and sacroiliac joints, are associated with ankylosing spondylitis. Evidence of the sacroiliitis on imaging, whether radiographic or magnetic resonance imaging, is considered a major inclusion criteria for the ankylosing spondylitis according to the assessment of the Spondyloarthritis International Society. ASAS is an society, and the ASAS is a detailed name like the Assessment of the Spondyloarthritis International Society in 2009, and which is an creates or establish axial spondyloarthritis criteria, and this criteria is very good guideline for us. And in a standardized plain radiograph grade scale exists for the sacroiliitis. The scale range from the normal to most severe, we can say 4 as detailed, and we consider 0 when the normal or the sacroiliac joint, sharp joint margin, we can and 1 is suspicious, 2 is a sclerosis and some erosion, 3 is a severe erosion and pseudodilation of the joint space and the partial ankylosis, and 4th is a complete ankylosis. So these are the 4, but we have to establish in a 5 manner, because we can consider the 0, then 1, then 2, then 3 and 4. So I will repeat the 0. 0 is the normal SI joint with sharp joint margins. You can appreciate the joint margin very well. In 1, when you are suspecting or it is suspicious condition. 2, when there is a proper sclerosis and some erosion on the plain X-ray. And 3, when the severe erosion, you can see severe erosion and pseudodilation of the joint space. You can see the dilatation of the joint space and the partial ankylosing. And when you will see there the complete ankylosis, then you can understand this is the thing. So here I want to tell you one thing. I took this picture from the internet and putting in my lecture here, and you can see how the beaking of the anterior body ages, and these are because of these marginal, we can say, appearances you can appreciate in the ankylosing spondylitis. So these are very, very important features, and definitely other feature I will mention here, but I just wanted to show you for the clarification. This picture I also took from the internet, and you can appreciate that there is how the appearance of the ankylosing spondylosis X-ray, lateral and AP, and this patient presented with the ankylosing spondylitis. This is pictorial presentation. In this picture, I think you can appreciate the normal spine, and then you can appreciate what are the differences in the early ankylosing spondylitis, and you can appreciate here the advanced ankylosing spondylitis, and in all 3 you can establish the difference in your mind. And then definitely when you are trying to deal such kind of patient, then everything clear, very, very much clear in your mind, then how the normal spine behave, how the early ankylosing spondylitis behave, and how the advanced ankylosing spondylitis behave here. So during the initial years of ankylosing spondylitis, plain radiograph changes in the, we can say, the sacroiliac joint can be subtle, and however these changes will usually become more evident over the first decade of the disease, and the most noticeable abnormalities and on radiograph are subchondral erosion, sclerosis, and joint fusion. These changes are typically symmetrical and affecting both sides of the sacroiliac joint similarly. Throughout ankylosing spondylosis, a series of the distinct radiographic changes characteristic can progressively develop, and in the early stage, a notable sign in the squaring of the vertebral bodies, which is the best visualized on lateral X-ray, and this squaring occur due to the inflammation and the bone deposition, and resulting in the loss of the normal concavity of the anterior and posterior border of the vertebral body. And additionally, early stage radiograph may reveal Romanus lesion, as known as the shiny corner signs, and then These characterized by the small erosion and reactive sclerosis at the corner of the vertebral bodies. And the late stage finding on radiograph include ankylosis. It means the fusion of the facet joints of the spine and the presence of the, we can say, the syndromorphites and the complication and the classification of anterior longitudinal ligament, supraspinous ligament, and interspinous ligament. This classification may be seen on imaging as the dagger sign and appear as a single radiodense line vertically running down the spine and frontal radiographs. This classic radiograph finding in late stage ankylosing spondylosis is the bamboo sign spine, which offer to the vertebral body fusion by syndomorphites, and the bamboo spine typically involve the thoracolumbar and lumbosacral junction, and this spinal fusion predisposed to the patient to progressive back stiffness. I will show you here the X-ray of bamboo spine. In my humble opinion, I think this is the best picture regarding to explain the bamboo spine, and you can see how the bamboo appearance and can mention here before I mentioned you, and you can appreciate very well here as I mentioned the bamboo spine. And one more thing, this X-ray showing how the cervical spine's behavior, and you can appreciate here, and we can appreciate how the cervical spine is bambooing of the bambooization or bambooing of the cervical spine. This picture also showing the in lumbar spine, you can appreciate the bambooization or bamboo spine. I think it's a good enough information regarding to understand the bambooization of the spine. And I must say this picture also telling the 100 words or the 1,000 words to understand the ankylosing spondylitis. I think when you see these kind of pictures, then definitely your mind has been cleared how the behavior of the disease and how the inflammation of the joints and how the fusion of the joint later and when the inflammation goes off, then the fusion of the spine and abnormal calcification happens at the joint area. And the same thing happen at the atlantoaxial joint, and when this happen in the atlantoaxial joint, it can cause some kind of a fracture and the neurological deficits. So as I was mentioning that the late stage finding on radiograph include the ankylosis fusion, or ankylosis means fusion. So ankylosis means fusion, and the fusion of the facet joint of the spine and the presence of the we can say syndesmophytes and the calcification of the anterior longitudinal ligament and the supraspinous ligament and the interspinous ligament, and the calcification may be seen on imaging as a dagger sign and appearing as a single radiodense line vertically running down the spine or the frontal radiograph. So the classic radiographic finding in the late stage of the ankylosing spondylitis is the bamboo spine sign, which refers to the vertebral body fusion by syndomorphites, and the bamboo spine typically involves the thoracolumbar or lumbosacral junction, and this spine fusion predispose the patient to progressive, we can say the progressive back stiffness, and we can say while the plain radiograph in the first line imaging modality in the ankylosing spondylitis, an additional imaging with MRI may be necessary to detect more subtle abnormalities such as the fatty or the inflammatory changes. An MRI can reveal active inflammatory lesions in the SI joint, and this appear as a bone marrow edema on the, we can say, the short tau inversion recovery, and we can say the T2 weighted image with the fat suppression. And it should be noted that the presence of the bone marrow edema on MRI can also be seen in up to 23% of the patient with mechanical back pain and 7% of the healthy individual. Treatment and management are very mandatory to understand, but we have to understand the treatment goal of the ankylosing spondylitis aims to alleviate pain, and we can say the stiffness, and preserve axial spinal mobility and the functional ability, and prevent the spinal complication. But the non-pharmacological intervention should include the regular exercise and the postural training and the physical therapy. So the first line medication therapy involve using non-steroidal anti-inflammatory drugs on the daily long-term basis, and if NSAID does not provide adequate relief, then can be combined with the substituted for the tumor necrosis factor inhibitor such as the, we can say, adalimumab, or an infliximab, or the, we can say, etanercept, so that the response to NSAID should be assessed 4 to 6 weeks after initiation, while the response to the tumor necrotic factor should be evaluated after, we can say, 12 weeks. So systemic glucocorticoids are not recommended for treating ankylosing spondylitis, but local steroid injection may be considered for specific cases, and the specialist referral may be warranted based on the patient's clinical presentation and the potential complication and extra-articular manifestation of the disease. So the rheumatologist may assist in the formal diagnosis, management, and monitoring of the ankylosing spondylitis, while we can say the dermatologist, ophthalmologist, and the gastroenterologist may assist with the associated non-musculoskeletal feature of the disease. So we have to understand here the systemic glucocorticoids are not recommended for the treatment of ankylosing spondylitis, but local steroid injection may be considered for specific cases, and the specialist referral may be warranted based on the patient's clinical presentation. So the potential complication and extra-articular manifestation of the disease rheumatoid arthritis may assist in the formal diagnosis, management, and monitoring of the ankylosing spondylitis. While dermatologists, ophthalmologists, gastroenterologists may assist with associated non-musculoskeletal feature of this disease, because this is a systemic disease and the chronic disease and the inflammatory disease, so these need the medical attention simultaneously, neurosurgeons input. Certain disease and the condition can mimic ankylosing spondylitis, and that must be ruled out. So this includes such as the mechanical low back pain. Sometimes you can, so we have to rule out there is other thing, or maybe the lumbar spinal stenosis, or rheumatoid arthritis, or diffuse idiopathic skeletal hyperostosis. Each of these diagnoses are similarities with ankylosing spondylitis, but their difference should be ruled in or out from the accurate diagnosis. And the mechanical back pain and the, we can say the ankylosing spondylitis, but their difference should be ruled in or out for accurate diagnosis. Mechanical back pain and we can say the ankylosing spondylitis can be distinguished and based on the several factors, and the onset of the symptom is a key differentiating factor, as mechanical back pain can occur at any age, while the ankylosing spondylitis typically present before the age of the 40, and unlike ankylosing spondylitis, mechanical back pain improve with rest, and morning stiffness is mild and short-lived. But the mechanical back pain is not associated with the peripheral arthritis and the extraskeletal manifestation commonly seen in the ankylosing spondylitis. Lumbar spine stenosis is a condition associated with narrowing of the spinal canal which lead to the spinal cord compression. Like ankylosing spondylitis, it may present with the chronic back pain and the morning stiffness. However, ankylosing spondylitis, or we can say the lumbar spine stenosis, usually present in individual older than 60 and is not associated with the peripheral arthritis or extraskeletal feature, and the response of the NSAID in lumbar spinal stenosis can vary among patients. So this is the difference between the lumbar spinal stenosis and the ankylosing spondylitis. Rheumatoid arthritis is another chronic inflammatory disorder of the joint that often present with the progressive back pain and morning stiffness in patient 40 or the young. So almost similar to the ankylosing spondylitis. However, the peripheral arthritis is highly prevalent in rheumatoid arthritis, but not in the ankylosing spondylitis. So another distinguishing feature of the rheumatoid arthritis is the presence of the rheumatoid nodules, which are pathognomonic for the rheumatoid arthritis and not usually you can see in the ankylosing spondylitis. In the same manner, diffuse idiopathic skeletal hyperostosis (DISH) is a degenerative disorder characterized by ossification in the spine occurring primarily in the anterior longitudinal ligament, vertebral, paravertebral tissue, and peripheral aspect of the annulus fiber. Like ankylosing spondylitis and diffuse idiopathic skeletal hyperostosis may present a history of postural changes and back pain, but unlike that was the similarity that the ankylosing spondylitis and diffuse we can say the idiopathic skeletal hyperostosis may present a history of postural changes and back pain, but unlike they are the dissimilarity or the no similarity of the differentiation between the ankylosing spondylitis and the diffuse idiopathic skeletal hyperostosis is not an inflammatory disorder and lacks inflammatory characteristics such as the morning stiffness or the improvement with the exercise, but not with the rest. So the diffuse idiopathic skeletal hyperostosis not exhibit any evidence of the sacroiliitis or radiographic changes. Here, if I come for the prognosis of such kind of patient, you know that the individual who experience an earlier onset of the ankylosing spondylitis are associated with poorer functional outcome. However, it is important to note that the several physical disability is relatively uncommon, as most patients can maintain a reasonable level of the physical function and head active and fulfill life. So here the patient with the severe and the long-standing disease have an increased risk of mortality compared to the general population, and the increased mortality is primarily attributed to the cardiovascular complication. If I will talk about regarding the complications regarding the ankylosing spondylitis are articular and extraarticular complication. So few are mentioned here, such as the chronic pain and disability, aortic regurgitation, pulmonary fibrosis, quadra equina syndrome, mood disorder. So these all are the complications regarding the ankylosing spondylitis. And we have to understand the chronic pain and disability, aortic regurgitation, pulmonary fibrosis, quadra equina syndrome, and the mood disorder. So the post-operative and the rehabilitation care, if I consider, exercise program have demonstrated significant benefit in managing ankylosing spondylitis, addressing pain management, flexibility, mobility, and overall function. While there is no specific protocol universally recommended for the ankylosing spondylitis management, so the multiple studies have shown improvement across various exercise programs, include home exercise program or the group therapies. So the hydrotherapy is one area widely cited for an cardiovascular benefits and pain management effect in individual with ankylosing spondylitis. So the respiratory and postural exercises are important factor in the ankylosing spondylitis as the disease process can impact proper breathing mechanism and posture. So the patient education is vital for the management of the ankylosing spondylitis. Patients should be educated about the chronic nature of the disease and the mechanism used for the treatment and their potential side effects, and there should be emphasis on the regular exercise program for reduce the symptom, and the physical therapy include the water therapy, hydrotherapy, and the swimming can be highly beneficial in reducing the symptom and improving the functionality and maintaining overall fitness. So giving the potential for the pulmonary improvement in ankylosing spondylitis, it is essential to emphasize the importance of the smoking cessation. Few people are continuous smoking, so smoking as a dangerous factor in case of the ankylosing spondylitis. And there should be high index of the suspicion for the vertebral fracture in patient with the ankylosing spondylitis even following minor trauma. Individual with the ankylosing spondylitis are at increased risk of vertebral fracture and the subluxation and especially of the cervical spine. Therefore these patients are more susceptible to the neurological compromise, and the prevention of disease morbidity can be achieved with the exercise and the physical therapy, or we can say the tailored for pharmacological intervention, or we can say an regainment following an appointment with provider. So ankylosing spondylitis is a systemic disorder that can affect multiple organs. So here we need the multidisciplinary involvement. We need the rheumatologist, we need the primary care physician, and we need the gastroenterologist for the inflammatory bowel disease. We need the ophthalmologist for the anterior uveitis. We need the cardiologist for the aortic valve regurgitation or valvular involvement. We need the physical therapist. Definitely we need the neurologist to assess the nerve compressions and the neurological abnormalities, and definitely pharmacists and the nurses and the paramedical staff regarding to help all the facility here. It is very, very important. Regarding the meta-analysis and the multiple studies demonstrate individuals who participate in an exercise program experience much better outcome than those are sedentary lifestyle and they are not going here and there, and the sedentary lifestyle may worsen that situation. I want to present one small case for the analogy here, and this is a 84-year-old male with a known history of ankylosing spondylitis present to the emergency room. 8 doses of the following: a ground level fall with progressive, we can say, cervicothoracic axial pain and limited range of the motion, and he reported the experiencing tingling in both hands after the fall, but these symptoms resolved within the couple of days, and he denies numbness, weakness, or the bowel or the bladder dysfunction, And when the examination done for him, it was found there is a 5 over 5 strength throughout in all four limbs, and 2 plus reflexes in a bilateral lower extremities, and sensation was intact to light touch and the pinprick, and no clonus or Hoffman sign, and the downgoing toes. So the differential diagnosis here definitely acute disc herniation, compression fracture, facet or the laminar fracture, cervical spondylotic myelopathy, central cord syndrome, vascular epidural hematoma, infection, for example, history of the immunosuppressant therapy or the discitis plus minus osteomyelitis, and the epidural abscess. Initial and imaging definitely I did for this patient. I did both the things, such as I did the CT scan for the spine, and which demonstrate the C6 C7 fracture with disruption of the perivertebral ankylosis and the fish mouthing of the intervertebral disc space, and in the MRI demonstrate associated prevertebral hematoma and the disruption of the disc space. So further workup has been done, such as the ESR, CRP, pre-albumin, or we can say the vitamin D, ionized calcium, and we can say here the imaging of the computerized tomography and the magnetic resonance imaging, but not only the spine, but the CT head, CT chest, abdomen, and pelvis, so we can assess all the area, and complete trauma workup may be indicated, because the bones are not that strong and there the easy fracture can happen, and patient may be not aware of that. So the consultation here, as I mentioned, we need the neurologist, rheumatologist. If there is eye problem, then we need the ophthalmologist and gastroenterologist, and definitely we have to advise the patient for the physiotherapy simultaneously. If I consider here that as we know, this is a challenging disease, and this predisposes patient to the major bony injuries from the low energy kinetic trauma or the mechanical fall due to the combination of the predisposition toward the osteoporosis and the loss of the dynamic force and distribution as individual vertebral element are fused into the single long bone. So then the fracture occur, and they frequently involve the intervertebral disc space, and usually it is spread from the ossification in the ankylosing spondylitis. So resulting in a high risk of the subsequent instability and neurological dysfunction. Ankylosing spondylitis is the third most common type of arthritis in USA, so affecting 0.5% of the population, and classically involving patients with the major histocompatibility complex scale, which is called the HLA B27 variant, and the primary theory for the pathogenesis suggests that the HLA B27 may be predisposed to the molecular and mimicry of the bacterial antigen when bound by a certain and a self-peptide, or alternatively may directly stimulate the autoreactive cytotoxic T cell activity, especially T CD4 and CD8 T lymphocyte associated with the macrophages, and this misfolding and the inappropriate dimerization within the endoplasmic reticulum. Clinically, patient complain of the image and quad equina from the ectasia, C1 instability, and these segments are speed. So we can say the chalk stick fracture you can appreciate here very easily. When I was thinking about my patient or this analogy patient, definitely we have to treat, or I have to treat, or I did treat like that the back pain NSAID and most effective and the short course of the opioid and the muscle relaxant and the progression of the disease and disease modifying anti rheumatic drugs such as the we can say sulfa alazine and no feature in the we can say here. And, so progression of disease, modification, anti-rheumatic drugs such as the sulfasalazine, but not effective in the axial spine with a small amount of evidence available for the methotrexate. Corticosteroid injection into the peripheral joint, it may affect and tumor necrotic factor antagonists appear to have more profound effect on disease activity within the spine and the mechanical such as the cervical collar for prolonged duration in patient without unstable fracture and the, or we can say chiropractic manipulation is not recommended and given the fragility of the spine and with this cervical spine being recommended due to the risk of the vertebral dissection. Pedicle screw fracture plus minus traction in patient with the kyphotic and the hyperlordotic deformity with the fracture and the reduction via light traction means less than 5 pounds is enough can be attempted following by the intraoperative reduction when needed and give the diminished purchase available due to the ankylosing spondylitis. So the construct particularly require extensive posterior instrumentation several level above and several level below to the injury and the anterior segment fixation rarely acceptable as a stand-alone approach for the fixation in ankylosing spondylitis fracture because the bone quality is important due to the low number of the feasible level, so can be combined with the pedicle screw fixation in patient with the we can say with the persistent deformity and the circumferential fracture or who are at high risk of the construct pull out. Wedge osteotomy with the pedicle screw fusion, most aggressive approach and ideally in the patient with the severe sagittal deformity unlike to be corrected with the above mentioned technique before as I mentioned just before. So preferentially performed for the injuries at below C7 to avoid the vertebral artery and should complication occur intraoperatively technically a difficult operation with high morbidity and the numerous variation have been described include those utilizing subsequent we can say the posterior spinal fusion to avoid immobilization post-operatively. Non-operative intervention, the high risk of morbidity in surgical treatment of the ankylosing spondylosis has led some to elect for heart collar or halo fixation, especially in those without deficit or frank deformity. However, progressive neurological injury has been found in over half of the conservative managed patients with other complications include the fracture non-union and skin ulceration, aspiration risk, and the pulmonary impairment. So the prone position with the neuromonitoring and the fluoroscopy for localization place the patient in Mayfield pin fixation. So this surgical technique I want to discuss with you here. This is the pedicle screw fixation technique and the prone position with the neuromonitoring and the fluoroscopy for the localization. Place the patient in the Mayfield pin fixation and subperiosteal dissection is performed bilaterally to expose the entire spinous process and lamina out to and include the lateral mass of the cervical spine and the medial edge of the transverse process of the thoracic spine. So the bony landmark and the ligamentous structure are examined for the evidence of the fracture or disruption. Respectively, screws are inserted into the lateral mass of the cervical vertebra and the pedicle of the thoracic vertebra with the angulation based on the anatomic landmark for the each level. And in the vignette, or we can say the C4, C5, and C6 were utilized bilaterally, but C7 are not instrumented due to the deep angulation, and bilateral pedicle screw were inserted into the T1 and T2 and T3. So as I mentioned, several level above and several level below here. And I want to give you one picture here, show you one picture, and just for the understanding of this surgical thing here. This picture also from the internet, and you can appreciate the how big level we are taking, because definitely and that is the right of the ankylosing patient, and that he has also right for the treatment. And if we have to do so, we have to go few levels above and few level below. As I mentioned, C3 C3 C4 C5 C6 we can take, and if we have to C7, we can't take the C7, when we have to go for T1 and T2 and T3, and this is the idea. Picture also from the internet, and I want to show you here that how long we go from the posterior in the lateral view, and in the other view you can appreciate there the how long or extended and lateral mass screw and the pedicle screw fixation in the cervicothoracic level, and how we are try to stabilize the spine and in that specific case. After a thorough decortication with the high speed drill, we can say the moralized bone allograft is placed to induce the arthrodesis, and the wound is copiously irrigated and closed in a layer and following in a hemostasis. So the neurophysiological monitoring is essential in these cases due to the high unstable nature of the fracture. So the post-operative CT and X-ray may be obtained to evaluate the reduction and the instrumentation. Few complications can happen, and how we can avoid, I want to keep in front of you how it is like that. For example, a CT scan is required for the pre-operative planning and the complete evaluation of the spine for the additional injuries is crucial in identifying the appropriate correction to restore the spinal alignment and balance and prevent inadequate reduction or construct length, and particularly if other fracture, even if chronic, become apparent at adjacent level to the index injury. So the detailed knowledge of the anatomy of the spine is crucial, particularly adjacent landmark, due to the fact that the central spine anatomy may be disfigured in ankylosing spondylitis. So detailed knowledge of the anatomy of the spine is definitely mandatory in every case, but definitely in ankylosing spondylitis, it is more mandatory than usual. So the landmark, due to the fact that the central spine anatomy may be disfigured, because here the anatomy of the vertebral body has been disfigured, and especially in the ankylosing spondylitis. So the extra pollution based on the remaining cues and combined with the judicious use of the fluoroscope and permit safe instrumentation placement and a thorough understanding of the spinal biomechanics is required to maximize long-term efficacy of surgical stabilization anterior procedure that could typically suffice to treat longer trocar arm created by the underlying pathology. So the transcranial and electrical motor evoked potential monitoring is an alternative for adjuvant to we can say adjuvant to the somatosensory evoked potential monitoring, and this potential we can say this is the transcranial electrical motor evoked potential monitoring, and above 20% of the reference value in all muscle group are as a strong predator or a predictor of the motor and preservation. And post-operative care must be taken by anesthesia team to avoid agent that may compromise the neurophysiological monitoring, and be wary of the epidural hematoma in the ankylosing spondylitis, because epidural tumors, epidural hematomas also you will find commonly in the ankylosing spondylitis. So this is all which I try to explain in front of you, and I hope you will like it. If you like it, please subscribe it and share it and support us. And if you want to, you have some question, you can ask directly. Thank you so much for this, your means support.